Hi, everybody. Good evening. I'm Dr. Brian Schillig. I'm the medical director and newest full-time emergency doctor at Animal Urgent Care in Fayetteville. I started my career many moons ago, quickly finding that I loved the adrenaline rush of emergency work. I worked at several emergency clinics in several states, winding down the first half of my career at a specialty and emergency clinic in Tucson, Arizona. After spending the last 11 years in my own small animal practice in Laurinburg, I decided it was time to get back to my passion, emergency medicine. And more importantly for me, building the kind of teamwork, not just in the hospital, but between hospitals, that leads to better veterinary care for all of our patients and clients. Fortunately for me, Vets Pets has the goal of doing just that as we move from animal urgent care into our new facility in the first week of August. At that time, presto changeo, we will become Points East Veterinary Emergency Hospital and truly become a sister hospital to Points East Veterinary Specialty Hospital in Wilson, North Carolina. We are really excited to bring our talented staff to work at a facility which will better serve their needs and the needs of our clients, patients, and referring veterinarians. Enough about me. Welcome to When the Danger Noodle Attacks, Snake Envenomation in Dogs and Cats, brought to you by Vets Pets and Points East Veterinary Specialty Hospital. This is a 1.5 hour North Carolina Veterinary Medical Board approved continuing education event. While thinking about your continuing education needs, save the date for our next continuing education event on July 27th. The challenge: one patient, multiple disease conditions, dietary focus, with Corinne Saker, DVM, PhD, and diplomat of the American College of Veterinary Nutrition from North Carolina State. As for tonight, let me now introduce my colleague, Dr. Mike Nystrom, diplomat of the American College of Veterinary Emergency and Critical Care.
Hey everyone, thanks for joining me. I'm sure all of you have had, I assume that many of you have had long days. So thanks for kind of tuning in to this. This will be my second talk that Vets Pets has allowed me to do. Hopefully many more to come. But as Dr. Schillig introduced me, some of you I think probably went to my last talk. I've met some of you as well, but my name is Mike Nystrom, the criticalist over at Points East in Wilson. I'm very lucky to be on board there, and I get a chance to talk with you about the danger noodle, also called the nope rope, what most people know as venomous snakes. We'll talk about kind of their presentation and a lot of stuff, how they pertain to our veterinary patients. I'm not going to do a whole lot of diving into literature. I try to stick just to more or less the basics. I think that's the most important thing, and I also don't dive strong into human medicine because we're not doing human medicine. So sit back, relax, hope you enjoy this. We'll have some questions along the way that you guys will enter A, B, C, D. I don't think we go up to an E anywhere. And just to kind of encourage some input from you guys and have some input to know where you guys are at. And then at the end, we'll kind of go through a little summary as well. So a little bit about me. So my journey to Vets Pets. This was the same spiel I gave in my last talk, but I'm a homegrown boy. I actually was born in Durham and grew up in the town of Cary. It makes me very sad sometimes to say I love Cary, but I do not live there anymore. I'm actually living back in Durham, thankfully. Thankfully to be back in the area. Very happy with Durham. I went to Appalachian State, home of the Mountaineers in Boone, North Carolina. Had a grand old time there, and then afterwards spent my veterinary veterinary developing career going to vet school at the University of Tennessee. This is their massive stadium. It's really fun to go to games here. And during game season, they have boats that line up and tailgate out here in the water. And you just walk all the way across the boats, which is really awesome and a lot of fun to do. They call it the Volunteer Navy, I think is what they call it, the Vol Navy. It's really fun. And then after graduating, I went to Tufts in the very cold Massachusetts. Loved it up there, very beautiful area, but very, very thankful to just spend just 1 year up there before returning back home to the South and back to Tennessee, where I did an ECC internship for a year. I was the guinea pig for that program at the University of Tennessee, and then also the guinea pig for an ECC residency, and was the first resident to go through the program. And then fortunately passed my boards whenever I took those in 2017, I think, 2018, maybe, I have no idea. But very happy for that. All right, so I do want to encourage you guys as you go along, if there's any questions that you guys have, you can type them into the chat. We'll have some breaks here and there that I will answer those questions along the way. So it'll probably be 2 or 3 times throughout the presentation where I'll take a moment to answer those questions. So any questions along the way, please feel free to type them in there. We'll also take questions at the end. Unfortunately, they're going to be all typed and then I answer them. So not one-on-one direct time, but all right, so a little overview of what to expect for this. First, we'll start off by talking about our envenomators of North Carolina. So these are going to be our venomous snakes that we have. I heard recently that we have a new friend, a new venomous snake in the Raleigh-Durham area. There's a, what was it? Not a tiger, a zebra cobra that's on the loose in North Raleigh. Actually live a couple miles down the road. My son goes to daycare there and they kept all the kids inside because of this. And I'm just like, guys, there's venomous snakes all around us. Why are we doing this for just a cobra that's actually very easy to see because it's black and white? But nonetheless, protecting the kids, I guess. But we'll talk about the envenomators that we have here in North Carolina. We'll talk about the types of bites that they kind of contribute to our patients, what we can see from our patients with regards to a presentation aspect. Then we'll talk about what diagnostics are useful to run. And challenge with this is that you can run all the diagnostics in the world, but it doesn't always mean anything significant, or it may mean something significant. We'll also talk about the treatment options, and then finally we'll go through the outcomes and what to expect with these patients as you kind of move through the treatment process for yourselves or these patients. All right, so this is probably the most important slide for me. This was an article put out, a clinical review that was put out in JVEC in 2011 that essentially went over discussing pit viper envenomation. And when we talk about pit vipers, most of the time we're talking about the crotolid species of vipers. We'll talk about what defines a viper ultimately, but it's not the only venomous snake that we talk about. But this article summarizes, for the most part, everything that you really need to know. And it does a great job in many ways. I think it does have a little bit of some holes in it. But ultimately, if you chose one article to read regarding snake envenomation, this is the article to read. And this is where most of this stuff was pulled from, and with some experience on the side as well. One other thing, this is a flow chart in clinician's brief that was actually put out by a criticalist named Adesla Odenayo. Coincidentally, when I went searching for this, I found it. She's actually my mentor. I had no idea that she had put this out, so kind of funny story there. But it's a flow chart that kind of gives you an idea if you don't want to go through all of this article. I think the article is about 16, 17 pages, maybe. But this clinician's brief article kind of gives a flow chart of how to approach an individual patient. Again, it does have some holes, some places that I think could have been filled in, but for a summary, it's a great resource for you guys to have. Hopefully you guys have access to clinician's brief. I believe it's free. Don't hold me to that. It's been a long time since I've registered with it, but I was able to gain access to it. All right, so North Carolina vipers +1, and that's that one that we're going to talk about that isn't actually a viper, but is important to know because it is a venomous snake that we have here in North Carolina. So probably the most common one that we see is, and I'm not going to pronounce these species, you guys can read them for yourselves and come up with your own way to pronounce them. But the eastern copperhead, we'll also talk about good old cottonmouth and why they call it cottonmouth, and then the eastern diamondback rattlesnake. I always love the rattlers, sometimes because you can actually hear them, most of the time not. Timber rattlesnakes, pygmy rattlers, and then finally the eastern coral snake. And the eastern coral snake is that +1, just because it's not technically a viper species. All right, so quick question for you guys. So which of these is the most common culprit, do you believe, is the most common culprit for snake envenomation in eastern North Carolina? And just as a heads up, this might be a little bit different depending on what area. Eastern North Carolina you live in, whether you're closer to the Piedmont like me, or closer to the coast, and also northern versus southern areas as well. But all right, let's see. So it looks like most people said Copperhead. We got one timber rattler in there, which is good. And I would 100% agree with this. Most of the snake bites that we're seeing probably are mostly related to envenomation with regards to the Copperhead. I will say that one of the ER doctors at, I believe it's the hospital PEC in Greenville, was discussing that they see more and more timber rattlers these days. That might be a location or locality area. The coral snake's probably going to be one that we don't see very often. Thankfully, it's got a pretty nasty neurotoxin, but it might be more commonly seen closer to the Fayetteville area and the southern, southeastern kind of tip of North Carolina. All right, so let me get back here in advance. There we go. All right, so there are a few species that do meet qualifications of the endangered species list. So these might be ones that we might see less of. This is one, the Eastern Diamondback, that whenever I actually came across this in one article, I found that it was an endangered species. When I searched for it other places, it was like, no, it's no longer considered endangered. So I have no idea. I threw it on here. Ultimately, it doesn't change anything for how we treat our patients, but just kind of an interesting fact. The Eastern coral snake is certainly one that we do not see around here very often. And then the timber rattler is one that's made the NC species of concern, which is kind of like the, I'm not quite endangered yet, but maybe I want to be recognized a little bit more. The timber rattler actually, I think, is a very pretty snake. But all right, so attributes of our envenomators. So how are we going to recognize these guys compared to, let's say, a king snake or just a normal water snake? That's not venomous. So a few of the attributes that can kind of help with guiding your clients if you guys want to try to give them hints. I always tell clients whenever they want to bring in a dead snake, I'm always just like, no, I don't want to see that at all. It doesn't change anything most of the time for me. Plus, I've had a couple clients that brought in 3 dead snakes and then 2 of them were alive when they brought them in. So that always terrifies me. So I'm just like, no, you can go put those in the trash can and please don't get bit because I don't need you to go to the ER as well. So the eyes are kind of one big thing that you can look at. So our venomous snakes will have these slitted pupils, just like cats do, as opposed to most of the non-venomous snakes will kind of have more of a round pupil like humans do. Additionally, the pit vipers will have these pit organs right here. That'll be between their nostrils and their eyes, and they'll have a varied number of them. So this snake here, I have no idea what snake it is. Quite a bumpy scales, but only has one. There's numerous snakes that have multiple. And so that's the pit organ that helps with sensing infrared, so that way they can see these nocturnal animals in the dark, potentially with heat receptors. This, well, I'm sorry, that says triangle-shaped head. I had not realized that it covered up that text completely, but the vipers and the coral doesn't quite fit this one, but the vipers have a very triangular shaped head and very broad base. So this would be a non-venomous snake, and it definitely has a triangular shaped head, so that can always be tough. But if you look at this guy and you compare it to this guy, just has these broad, he's got like these big old jowls. That's kind of a big difference between them. And lots of times, and I'm not 100% familiar with snake anatomy, but I believe that their venom glands lay somewhere in those jowly areas. I'm not sure what the difference is in their vent. This is just part of the picture, but I wanted to get this statement up here. So we'll ignore the vent because I have no idea what that's discussing. And then the last thing is particular colors. So some snakes have particular colors that might make them more concerning or might differentiate them one snake from another. So this is on the left here, down at the bottom is an eastern coral snake, which is venomous. The one on the right, I believe, is a scarlet king snake, which is not venomous. So although they look a whole lot alike, and if you just see them out in nature, I'd run from either one of them just to be safe. Better safe than sorry, right? Again, one other picture here, slitted pupil compared to the round pupil, and then the pits compared to no pits. All right. So another little drawing that I found, this was one that happened to pop up from Tufts. I'm not trying to sell Tufts on anything, I promise. It's just, they had a nice little chart here, kind of comparing one venomous snake to a non-venomous snake and how they can kind of be confused with each other. So in particular, you see this broad-based triangular head compared to a kind of more rounded head for each one of these guys. And then they have similar colorations, and that can kind of be the thing that kind of throws you off and gets you to be like, oh gosh, I need to step back. So always, I would say, err on the side of caution and stay away. Would be kind of a big thing for these guys. But all right. So question for you guys, next one. So how many envenomators do you personally end up running into, whether on a jog or on a hike, in a year? And hopefully we'll get our poll up here in just a second. There it is. So how often do you guys get lucky enough to run into one of these friends? All right, let's see what you guys got. All right, so a little under half of you see them less than once a year. That's probably a good thing. I'm sure we all prefer that. Gosh, almost, I guess 11% of you, so 4, see them very, very often. So, I here in Durham, I probably see them 2 or 3 times a year or so would be my guess. I'm only ever seeing copperheads up in these areas. I would love to see a rattler just because I think they're fascinating, but I would also have no desire to run into one. I've got 3 kids and a dog and cat that's an indoor outdoor cat. So I hope that they never run into any of these on their own. But all right. Let's see. So we'll talk about each one of them individually here. We'll start off with our good friend, the copperhead. This is, like we talked about earlier, probably the most common culprit in eastern North Carolina to cause issues, just because it is so prevalent in eastern North Carolina. They have this beautiful leaf-like pattern to them. And so if they were laying in a bed of dead leaves, besides being maybe a little bit brighter than those leaves, you might not even recognize them. This was actually one that was posted to a neighborhood post of mine. And this was found right off of a sidewalk, which is just terrifies me to think about in a kind of busy suburb neighborhood that these guys can just be kind of hanging around. Copperheads get up to about 4 to 5 feet in length. So they get to be a pretty decent size. And their girth is probably, I don't know, 2 or 3 inches across or so. And then similar to what I just stated, this is another one off of a sidewalk, but they're found in all kinds of settings. So most commonly they're kind of in wooded areas and they really just want to be left alone. But you can find them moving through grass, moving around on sidewalks, gardens are probably some common areas. I found a bunch of juvenile copperheads or freshly born copperheads. I don't know what they really classify as. Not quite adolescents, I guess, around a lot of gardens. Typically, their attack is only in a defensive manner. So they're only going to attack if they get touched, is what we typically find. So they'll sit there, they'll freeze, they'll be nice and cold up and pretty. You leave them alone, they'll leave you alone, is what they want to do. But of course, dogs never leave anything alone that seems interesting on the ground. And then their venom will most commonly cause tissue swelling and damage. So it doesn't often cause issues with regards to significant systemic signs, but it's always a possibility with each one of our species. All right, the cottonmouth. I've not actually seen one of these. Maybe I have, and I just didn't realize it. It might just be their defensive habit that ultimately gets you to recognize that it is a copperhead. This is, interestingly, the world's only semi-aquatic viper, meaning that it spends a lot of time in water, it spends a lot of time on land, but it is the only viper that does that. The rest spend time around water, but not typically in water as the primary part of their habitat. They are named cottonmouths because they do this very interesting open mouth threat display. So they'll kind of coil and create a little circle around themselves, and then they lay there with their mouth open. And it looks like copper. And actually, if you look close enough, I believe these little curved things don't, again, I'm not about anatomy on this, but I believe those are his fangs. Interestingly, that they don't pop out whenever he opens up his mouth. So, but this is a common defense mechanism to say, hey, back off, I'm here, leave me alone. They usually only get up to about 3 feet in length. So not quite as long as the copperhead, but their girth will often be a little bit more. So the girth of this one here in this picture is quite a bit more than the copperhead pictures that I just sent you guys or showed you guys. Their coloration, they're often dark brown to black, and you can actually see that they do have some degree of striations on here as well. With time, it seems like those fade with their age. And then the other thing that's kind of very interesting about them is that they often, and I couldn't find a great picture of it, but they often have this kind of, come here, mouse, a shorter jaw or shorter mandible than they do, I guess this would be maxilla area. So they kind of look like they have a shortened jaw, which is kind of just gives them this little snub nose look to them. And then similar to the copperhead, these guys will typically only strike when physically touched. So if you leave them alone, they'll leave you alone, just march on and kind of move on with your day. And hopefully they'll move on with their day and everyone will be happy and alive and nobody will get hurt. All right, so the Eastern Diamondback, one of the more pretty ones that we'll talk about. This has a diamond pattern on its back as it refers to the diamondback, right? So if you look, and this is an artistic depiction, but they have these black and brown diamonds on their back, which is very easy to identify them along with this thing that rattles. So that should make it easy, right? These are similar to the copperhead, kind of more common in wooded areas, but you can also find them in low-lying water as well. So that's also a possibility. They are a little bit bigger, so these guys get up to 6 feet in length, and their girth is often quite a bit more than the copperhead. So they're going to be a bit more girthy like the cottonmouth, but definitely more so than the copperhead. And then they have a very, very well-developed rattler. So if you hear a rattler in these areas, most commonly you're probably going to be hearing this Eastern Diamondback rattler. Will be the most common species that we'll see around here probably. And then in human medicine, like I said, there's not going to be, I don't like going into human medicine, but just that way, kind of a reference, these are considered extremely dangerous in human medicine. And the reason for that is that they typically are not afraid of humans, meaning that they will go into a defense and they will try to avoid interaction with all that they can, but they're also not afraid to fight. Unlike the copperhead, unlike the cottonmouth that are kind of going to sit back, lay low, just be like, hey, you leave me alone, I leave you alone. These guys are kind of more pumped up, ready to fight. They're more like a terrier, I'd say, ready to get out there and get some interaction with some things. All right, timber rattler. These guys are very similar to the Eastern Diamondback, but they interestingly have these zigzagging bands across their back. So this is a perfect picture of these zigzagging bands, a darker brown to black coloration across their back. Sometimes, most of the time they connect like this, but sometimes they don't. And then of course, the rattler, very easy, right? These guys will get up to 5 feet in length, so not quite as big as the diamondback, but still a decent size. This is one where you can see that the zigzags don't quite meet up in all places, but you can kind of get the idea that they do have a zigzaggy pattern. And again, the rattler to help you identify that, hopefully. These often live in kind of more rugged terrain, more deciduous forest areas as well. And they have a kind of mild disposition. So these guys aren't quite as aggressive as the Eastern Diamondback, maybe a little bit more aggressive than the Cottonmouth and the Copperhead. Either way, don't mess with them. And they also have very large fangs. Not that that terribly makes much of a difference, but it might be allowing them to essentially inject more venom each time that they bite if they decide to. All right, the pygmy rattlesnake, this is my favorite one of the group, ultimately, just because they are very pretty. And I'll show you a picture here in just a minute. These are not common. And ultimately, they're not common just because they're not common to be the cause because they're not very common in the area. So they're smaller, much smaller, so up to about 2 feet in length. So dramatically smaller than both or actually all 4 of the other species that we've talked about. But definitely a lot smaller than the timber rattler and a lot smaller than the Eastern Diamondback rattler. Their rattler is very small, so instead of making a nice little shaking sound like a maraca, I think that's what that is. Hopefully I'm right on that. It's been a while. It kind of it sounds more like a little buzzing sound. So like a hummingbird buzzing around you, a bee, or something like that. And then of course, as you can tell, very pretty, this light gray to blue color with some orange. So very, very pretty snake. They're more common in the eastern side, the further east you kind of go. So less common in the Piedmont area, more common in the coastal plains area. And again, they're not very common to be the cause. They often have a small amount of venom that they can inject, probably in multiple parts, just because one, their size, two, I think they have smaller fangs as well. But they're less likely to be fatal in humans, which also probably means they're less likely to be fatal in our dogs and cats, hopefully. All right, so quick question before we get to our last friend. Which is true regarding the eastern coral snake? Hopefully all of you guys might recognize these sayings. So is it red on yellow, kill a fellow, black on red, end up dead, red on black, venom lack, or black on yellow, let it mellow? All right, so most of you got it right. So red on yellow, kill a fellow. Black on red, end up dead is actually, we'll go over this next, but the black on red is more typical of a non-venomous snake. Red on black, nobody guessed that one, that's good. Interestingly, black on yellow, let it mellow was just another way to try to see if I can catch you guys off guard, but that actually does fit for, I believe it fits for the coral snake as well. But red on yellow, kill a fellow is kind of how many people learn it, or some adaptation of that. Red on yellow, kill a fellow, red on yellow, let it mellow kind of situation. So good job. I thought I'd get more people on that one. I'm disappointed in myself. All right, so the eastern coral snake. We'll talk about which one is the coral snake and how to identify it compared to the non-venomous version. This is one little sample. Again, red on yellow, or red and yellow, kill a fellow, versus red and black, venom lack. So the coral snake's gonna have red bands that touch the yellow bands. That's kind of the big difference. Whereas these non-venom, and ignore this thing that says sample over here, I just had to take a picture that I can get here and I didn't cover that up. So the milk snake here, similar to the king snake that we had earlier, has a black band on a red band, or a black band on a yellow. So mostly we're talking about, we'll go with the red and black aspect and the red and yellow. So here, you don't have any red that's touching yellow, so you're probably good. And so that's what you're hunting for. Either way, you see these guys out there and you're in eastern coral snake territory, probably leave the thing alone. Nobody needs to get bit just for kicks and giggles. Again, here's the two of them together. So this is going to be your eastern coral snake. And I just happened to choose a picture that was more similar to this one, and they were similar to each other. But so they're not always going to look perfectly like this. But red on yellow, not good, kill a fellow. Red on black, friend to Jack is how I actually learned it. Or venom lack. So, all right, there you go. So everyone knows how to be an eastern coral snake expert. Again, this is a Texas coral snake. They're practically the same thing, more or less. All right, so talking about the eastern coral snake. Talked about red on yellow, kill a fellow. I can't beat that into anyone enough. These guys are actually surprisingly longer than I thought. I always thought they were a lot smaller than they really are. But they can get up to 4 feet in length, but they don't get quite that big girth that the rattlers will get, which I'm not quite certain why that is, that they don't get as quite as girthy. They are uncommon in North Carolina. But if you live in this little smidge down here in southeastern North Carolina, that might be where you'll be more likely to see them. I have never run into one, thank goodness. In my tenure in North Carolina, I've never run into one, period. I hope I don't ever have to. I would love to see one in a aquarium or terrarium at some point, just to see how pretty they are, but that would be about it. Otherwise, I have no desire in the wild. All right. And like I said before, these guys have a potent neurotoxin, so they're going to cause neurologic signs. It's going to be one of the big things. So you'll see that animals that have difficulty walking or might be completely plegic, and they might also have respiratory signs due to respiratory failure of the the neurologic mechanisms there as well. So no bueno, nobody likes this one. And these guys have very, very small things, very, very small head, very, very small things. So fortunately for us, they are less effective at envenomating species, whether that's humans or dogs and cats. So just one thing that is a benefit, I guess, there for us at least. We're just checking kind of time where we're at for that. All right, next question. Which of these are the most common venomous snakes that you have encountered in your life? I feel like this is pretty similar to one that I had above maybe, but maybe a little bit different. And again, this picture here in the background, if you look, you got red on yellow, no bueno. You don't want to mess with that guy. All right, no surprise, the daggone Copperhead. So rolling the roost. Got some Eastern Diamondbacks. I'm so jealous. I'm actually jealous that nobody's seen Pygmy Rattler, Cottonmouth, and then Coral Snake out there. Oh, how exciting in a terrible way. So hopefully you don't have to run into any of the side effects or dogs actually getting, or cats getting envenomated by those coral snakes. Gross. All right, so let's see. Taking a little break here. So if anybody has any questions, go ahead and type them up here and I'll see if I can answer them while we take this break. The smallest snake in the world is the Barbados thread snake. I don't even know if all these pictures are thread snakes. I think a couple of them are, but I don't think all of them are. This, oh gosh, sorry. This one looks a little bit different. This one looks like a worm with a mouth, honestly. I thought it was quite goofy. I have no idea what these guys eat, but they can't eat anything that's really big. But essentially 4 inches, so a little bigger than the size of a quarter with regards to whenever they're coiled up. So kind of cool. I just thought it was very interesting. Love to see one, just to see what they feed it. Maybe some ants or something like that. So, all right, any questions? No questions. So either people are sleeping or I'm just doing that good of a job out here. I'm gonna go with sleeping given what time it is. All right, we'll go ahead and move. There's a question. Oh, it makes me so happy, Doc. Thank you, Dr. Clements. Oh, no question. There's a Facebook group called NC Snake Identification and Education that is fabulous for learning to identify snakes. Well, thank you. So Facebook group, NC Snake Identification and Education. That's just quite a mouthful. So if you want help with learning about snakes, I appreciate it, Dr. Clements. So, all right. Again, feel free to chat any questions and I'll answer them at little breaks here and there throughout this. All right, so we'll talk about types of bites now. So this is something that I always found was very interesting. And ultimately, I don't think it really matters many times for us as veterinarians, because most of the time we're going to see patients that are probably likely to have gotten a full-on venomous bite. But I never knew before my residency that we actually have dry bites in venomous snakes. And so these are bites that do occur where the snake will actually strike an individual. This happens in human medicine and in our veterinary patients, and they just won't inject any venom into that individual. And so they can still sit there and stab in their nasty little talons of fangs into patients, and so it can still leave marks, but they don't inject any venom. And so essentially this is a voluntary control that they potentially have over injection of venom. And then you have venomous bites like this terrible creature here. Probably would inject quite a bit of venom. I don't think that one would have so much control over its venom, but I always thought that this control of the venom was quite an interesting thing. The coral snake, interestingly, is probably less capable of controlling these venom injections compared to, let's say, one of the other vipers, whether it's Copperhead or Cottonmouth or one of the rattlers. And the dry bites probably account for up to 50% of bites that occur. This is actually a statistic that I believe, I want to say it was probably pulled from human medicine. Clearly, there's probably tons of bites that happen on dogs and cats that never come into the hospital. So you can just assume that since they don't come in, maybe it was a dry bite and maybe it just was not as severely affected as, say, the ones that we commonly see that come in with big blown up faces or big swollen legs and paws. So kind of interesting. There is this belief that snake bites to youth, not like these guys, fortunately, but these guys, so kind of the younger adolescent newborn snakes, it's believed that they may have a lack of ability to control how much venom they inject into a given portion or a given individual or animal. And so that's a belief that is thought to be the case out there. But interestingly, when I did this presentation, I actually went back and researched this, and there's a number of studies that are actually out there looking at this, and they found that juvenile snakes do not necessarily inject more venom or less venom than adult snakes. This was a paper that looked at venom metering, so how much venom is injected on each bite in juvenile prairie rattlesnakes. So I'm not sure what those look like. I'm sure they're probably pretty just because they're rattlers. But essentially what they did in this study was they exposed these snakes to, I think it was mice, smaller mice. Yeah. And they exposed them as naive snakes to see, how much venom they could inject into a patient or inject into a mouse. And then they had an experienced group, which was the group that had already seen a mouse before and seeing if they would inject more or not. And essentially what they concluded was that rattlesnakes with experience, so experienced rattlesnakes, often would meter or inject more venom into larger prey compared to smaller prey. And so it suggested that they control it on their own. And this was even present in juveniles. So just because a snake is young doesn't mean that they're going to inject more or less, but it often has to do with the prey, and it often has to do with experience of what that snake has been through. So larger prey, probably us humans, dogs, compared to, let's say, a mouse or a little bird or something, probably going to get more venom. So maybe that's why we think that they inject more venom, but I don't know if it's really any kind of significance. Ultimately, they are going to inject venom if they want to, so it sounds like. All right, so a little bit more about venom metering, aka venom quantity injected, multiple factors. We already talked about the size of the prey, also the size of the snake. So if we look at our little eastern coral snake, or snakes that have smaller fangs, they're probably not going to inject as much. The larger snakes, like our eastern diamondback, the biggest of this group, probably going to have more venom to inject if it wants to. There we go, a little fast there. And then the circumstances of the bite. So was a snake surprised whenever they attacked? So this would be like the dog that just runs up on something and then the snake just reacts real quickly, gets startled and reacts. They're probably going to be more likely to inject larger volumes of venom compared to one that's just kind of sitting around, sees a dog coming up or sees a human coming up, coils up, and then is doing its defensive behavior like the Cottonmouth, and then ends up deciding to do a defensive strike. They're probably going to be ones that are going to have more of a dry bite or maybe less venom that's injected. And then last thing to consider, and this has nothing to do with our dogs, more the human side, is whether or not bearskin or through clothing. I think you can probably also maybe include dogs with lots of fur compared to dogs without, long-haired cat compared to normal domestic short hair kind of cat situation, kind of a similar circumstance, I guess in theory would be possible. All right. The biggest, most important thing is the size of the snake probably has the biggest effects with regards to how much an animal will inject ultimately. All right, question. Has anyone ever been unfortunate enough to actually have been bitten by a venomous snake and envenomated by them? I'm really curious to see who's gotten the short stick on this one. And if you guys are not close to wood, just knock on your screen there. If you choose option 3, I'll put a little piece of wood there for you. We'll just pretend that it's real wood and actually in front of you. Oh, sweet. Nobody's been bit. That's a great thing. I was actually really looking forward to hearing someone's story at some point saying, yeah, I was bit and it was terrible and this happened, that happened. But good for everyone that they didn't get bit. And so I'm very glad to hear that. I did hear of a story one time. It was a friend of a friend who got bit. I think it was by a copperhead. And they ended up in the hospital. Apparently in human medicine, it's no joke with regards to getting bit, unlike our dogs and cats, which we'll go over their clinical presentation and how to approach them. In human medicine, you don't take a chance. You hospitalize them for 1 to 3 days. It sounds like everyone gets anti-venom. So don't mess around. You get bit, get to the hospital as soon as possible. Always a good recommendation. All right, let's see what's coming up next. Oh, Venom Toxins. Of course, we're not talking about this guy, Venom, the Spider-Man nemesis character here, but talking about our venomous snakes. So there's multiple classes of toxins. This is going to be something that I'm going to brief over. You guys have it here. If you're really curious, you can dive through everything. You can try to find the mechanism of action of each of these toxins. Good luck. Have fun. I wish you the best. But they can kind of be quite in depth. But if you love that kind of thing, by all means, go for it. The vipers in themselves have probably up to about 50 different types of enzymes, or what we call the toxins. So large categories or large number of toxins that they can have. And each snake is going to have their own cocktail. So it's not usually just that a snake has this one toxin or enzyme and another snake has this one. They usually have a combination of them, with the ultimate goal of these toxins being to immobilize the prey, one, and then to start the process of digestion, which is kind of gross to think about. Ultimately their goal is to essentially start breaking down the pet. But I guess in theory, not the pet, let's say their prey. I guess in theory, it kind of makes sense to start from the inside and the outside. With regards to these, you inject some venom, they're starting to die off into gross inside internally, and that might make digestion of these animals a bit easier for these snakes that do the ingesting. All right, so what venom toxins do we have? Again, I am not going to go through these at any kind of length besides just mentioning them. Probably one of the biggest ones that we does have significant effects is this phospholipase A2 enzyme. This is going to be important for recruiting a lot of inflammatory white blood cells to the local site. It's going to cause also our red blood cell abnormalities that we'll see. So the echinocytosis, the spherocytosis, where they have changes in the red cell shape. And we'll talk briefly about those later on. Additionally, phospholipase A2, if you guys remember, on your cellular membrane, you've got, excuse me, you got a bunch of phospholipids. Phospholipase A2 will break down some of those phospholipids and then potentially cleave it into a thromboxane pathway, or the other one is our COX pathway, cyclooxygenase pathway. So when we talk about the thromboxane A2 production, that's going to have effects on our platelet aggregation and can lead to thrombocytopenia developing in these patients. Thromboxane A2 is where aspirin takes effect. Yes, and that's why it's beneficial in patients, in human patients that are having heart attacks, because it's less likely to cause platelet aggregation, so it'll help with preventing that. That is not me sitting here saying that's a treatment for these envenomations. Don't do that. But all right, other toxins, we got kind of lots of these ACEs in here, phosphatases, exopeptidase, hyaluronidase, L-amino oxidase, proteases, hydrolases, and many, many more. These are just kind of some of the more common ones, maybe ones that you might recognize. Ultimately, they all start to cause tissue necrosis and can lead to coagulopathies based on how they affect the body, how they affect coagulation cascade. That's kind of the big thing. Don't worry about their names. They cause all kinds of havoc, and these are just some of their names that if you want to be a big nerd, I encourage you to be a big nerd. I'm not that big of a nerd for that, but good luck, guys. Nerds are cool, by the way. I'm good with nerds. All right, so clinical presentation in patients. So what are we going to see in our patients whenever they present to the hospital? Usually we're going to see signs within about 30 minutes of envenomation. And so many times Clients won't even know their dog's been bit. They might be like, yeah, they were outside playing in the backyard, and then all of a sudden they just came in. They just kind of looked a little bit skittish, and then all of a sudden I turn around and boom, their face is just huge. It's just like, come on, there's no way that really happened. But sure enough, I mean, that's probably 70% of the presentations that we have, and then we're making the diagnosis based off of a presumption. But owners will often notice this massive acute swelling. And so what this is a lymphedema of the face, well, of whatever tissue is actually bitten. The face is the most common site for dogs. Following that is the limb, and then less commonly is the trunk. If you think about it, dogs investigate with their face like big dummies. Cats are going to investigate with their limbs, sticking back and patting it. And I'm not sure why any animal would ever get bit in the trunk unless it was just rolling over on a snake, which would be extremely unfortunate. And oftentimes these sites will have a little bit of some exudative discharge from the puncture sites, and that might be kind of a helpful indicator. With that being said, I'd probably bet that 40 to maybe 60% of dogs that I see for snake bites, or what we suspect are snake bites, probably don't have any puncture wounds at all. I see lots of ER doctors from time to time, especially interns during my residency, that'd be like, oh, there's puncture wounds right there. I'm just like, you're out of your gourd, man. I'm not seeing anything, but if it makes you feel better, go ahead. So oftentimes you're not finding puncture wounds, but that doesn't necessarily mean that it's not a snake bite. So the other thing to remember is that there are other things that can lead to envenomations in North Carolina if you're unlucky enough to live in an area where they have scorpions, but spiders also can lead to envenomations and can lead to pretty nasty things as well. All right, oftentimes we'll see kind of a hemorrhagic bruising to the area acutely, and that can be pretty rapid when you think about it. And then it often leads to progression, kind of a spreading out from the primary site. And then these patients I often find are quite painful. Even if they don't have a significant amount of swelling, you just look at them and you start to, touch around the site and they just go bonkers. So one thing to remember is pain medications. Try to keep them as comfortable as possible, because that's going to be a big aspect of their care moving forward. All right, so the dog versus the cat. As I already talked about, dogs like this dummy here are going to be more likely to kind of sniff around and investigate with their nose, thus leading to bites on their face. I believe this is actually a picture that I got from one of the vets at PEC in Greenville. And interestingly, I'm not sure why this is, but it seems like dogs are a little bit more susceptible to the venom toxins than cats are. And I don't know if this is maybe just a misrepresentation because there are more dogs out there, or there are more dogs that are being brought into the vet. Maybe cats just kind of go hide in a barn or something. But it seems like dogs seem to be a little bit more susceptible to them. Cats kind of have less of a, in my experience, maybe less of a pain response to these venom or envenomations. All right, so the kitty cat, like I said, more distal or more likely to have limbs, and that's ultimately they see something. They're the ones that are smart and they kind of stick out their arm like this, if you can see me, as opposed to sticking their nose straight up in a snake's face. So probably the smarter of the two species altogether. But if you guys attended my fluid therapy talk, cats medically, I'm not a fan of, but I am a cat person though. And again, they're probably less susceptible to the venom toxins than say the dogs are, which is very interesting to me. And I'm not sure the reason. This is a cat that presumptively got bit here on the distal paw. You can see kind of this focus of more significant bruising and redness kind of spreading out through there, but you can also see that there's edema moving up the arm and probably some pitting edema based on what it looks like with that nurse holding the pet's hand with gloves on. I'm so proud of whoever's wearing gloves in that picture. Thank you. Makes me so proud, especially around wounds. All right, so systemic signs on our dogs. So what are we going to see for these guys? And these are often non-specific signs. You can see them just be lethargic. This is a dog that got bit in the face. I'm not sure what's normal coloration for this dog and what's abnormal, but I'm assuming that everything this direction is abnormal. And that looks terrible. He also has some bruising down here on his chest, or he or she has bruising down here on their chest as well. And I'm not sure if this is bruising back here or not. But pretty gnarly, looks pretty terrible. It almost looks like this dog is dead because it's not really opening its eyes, but I'm hoping that it's not because this picture was sent to me as well. But oftentimes you'll see dogs that they kind of come in for ADR type signs, which makes sense. I mean, if you just got bit by a snake, holy crap, I bet you feel pretty crummy too. It's not uncommon for them to be hypotensive, whether that's an acute shock due to the adrenaline of the situation and just going bonkers and not knowing what to do, or actually side effects of the toxins themselves. So certainly something to look out for in any of your patients coming in on emergency, and you suspect that they might have gotten bitten by a snake. Tachypnea, whether related to pain or don't forget that the shock organ in a cat is the lungs. Not uncommon for dogs also to develop a vasculopathy or vasculitis due to these. PTEs are thankfully not very common, but possibility as well. And then tachycardia. I mean, every animal coming into the hospital, especially on an ER type basis, is going to be tachycardic. But these guys can be pretty impressively tachycardic. So a dog approaching 200s or higher, cat approaching 260 to 300 certainly is not uncommon for these guys. A lot of it's due to the pain, but hypotension can also be a contributing factor to that. And then depending on what they got bit by, neuropathies are also a possibility. Hopefully not the eastern coral snake, nasty critter that it is. And then coagulopathies with hemorrhage. And this is kind of an interesting aspect of envenomations in dogs. And there's been a number of discussions about what type of coagulopathies these guys have. And I'll have a little bit of a discussion about it later. I don't get into a whole lot of detail. Ultimately, most of the coagulopathies just will lead to focal bruising and hemorrhage from, I'm assuming this is a puncture site right here, maybe, hemorrhage from that puncture site. Some animals will develop petechiations, but hopefully most of them will resolve spontaneously without any kind of significant intervention. All right, so timeline. What do these owners do? You have an owner that calls you, they say, hey doc, my dog just got bit by a timber rattler. I have his head. Do you want me to bring it in? What should I do with my dog? And you're just like, I don't care about the head. Take a picture of it. That's fine. I don't want anything to do with the rest of the snake. Maybe keep the rattler just as a little gift, but if you already killed it. But these pets should be evaluated pretty abruptly. It's always recommended. I would say that probably, in my opinion, probably close to 70 to 80% of dogs that I've evaluated, and probably a good chunk of cats as well, that have been envenomated by a snake, often probably don't need significant care. But you never know. Always be safe. CYA kind of situation, cover your bottom. CYB maybe, and recommend that they be seen, whether through an ER clinic or through your own hospital yourself. These patients, one thing to note is that they can have delayed effects up to 24 hours. And this is within the acute time phase. This is not talking about they're going to be better in 24 hours or not. But that 24-hour time period is kind of the key where things can go down south very quickly and not do well, or they can continue to improve and recover and do great. The wound aspect of animals often will take a little bit more time to declare itself. So if we go back to that, I believe it was a Westie. That's a dog that I wouldn't be surprised if it develops kind of a oozy wound for the next couple of weeks coming from that cheek spot. But I certainly can't condemn an animal just because they have a lot of tissue necrosis. And I wouldn't certainly on a limb go, gosh, they're going to lose all of this. This dog is toast. We might as well amputate now and just take care of this for this pet. So give them time. It's amazing what animals can recover from and what they can do on their own, which is always very fascinating to me. So get them in quick. Be careful. It wouldn't be wrong to evaluate them in another 12 to 24 hours if they end up going home, just to make sure that they are doing their best, even if it's just like a brief exam. All right, you're doing great at home. You're eating great. You're comfortable. I love it. Go back home and continue what you're doing. All right, so the diagnosis, I've already mentioned this a couple times. Most often, we're going to have somewhat of a presumptive diagnosis. I'm not sure where I got this picture. If I got it from, I think I got it from a colleague, but this is going to be a negative point here. They're not wearing gloves, and this dog definitely has a wound, but it's okay. And it's a puppy. Oh my gosh. People that work with me are probably thinking I'm going to die tonight after saying this. But so this dog, this dog shows up. It looks like it's got this very focal lymphedema over here, what we call it. Interestingly enough, this dog doesn't have a whole lot of bruising, maybe a little bit right here, but ultimately not very much. So I might look at this and go, is this a wound from like getting caught on the fence? No, that doesn't quite make sense for all the swelling. Is this maybe a spider bite? Maybe. I feel like they're less likely to bruise compared to snake bites. Ultimately, it doesn't really make a difference. Your approach to them typically is going to be pretty similar. Wearing gloves, exam, pain medications, and supportive care. We'll go over all that in just a little bit. All right. Again, I mentioned this earlier. Most owners have no idea what happened. There are some that are just like, yeah, we were outside playing, throwing ball, and all of a sudden just shriek, dog runs off, and then we go over there and there's a copperhead sitting right there. And it's just like, well, hot dog, you better run too. At least your dog had the right idea after it got bit. But many owners will notice these changes within about 30 minutes. Most interesting case I had actually of a snake envenomation was, if anyone remembers when Pokemon Go came out, there's that little, I think it was on the phone, and you just walk around town or walk around your house and you find random Pokemon all over the place. I had a dog come in because owners were out with the dog, and it was like a family of 5 or 6 or something. And they came in and there was like, we were out playing Pokemon Go and our dog got bit by a snake. And I'm just like, what? Are you serious? So that was a highlight, just to be like, wow, that's really unfortunate for your dog that you're out playing a game on your phone and your dog got bit because no one was paying attention. Probably coincidental, but I always like that story. It makes me laugh really good. But yeah, and then as a heads up, it's not uncommon for dogs to be repeat offenders, especially in the area that we live in. Eastern North Carolina, as I'm sure many of you are aware, have lots of hunting dogs. These guys certainly are predisposed because they're out there in the trenches with possibility of these snakes. So probably a lot of repeat offenders. This might come into play with regards to how you approach treatment on these animals. There is a possibility that it's believed, some people believe, that there is a likelihood of these guys becoming hypersensitized to the venom effects. And so they might not have a big reaction to the first one, kind of similar to a bee sting, but the second envenomation might be more dramatic, third, even more so. I can't say I've seen lots of repeat offenders. I hope that I don't see repeat offenders, knock on wood here, but it might not be uncommon, at least repeat owners with regards to if they have a kind of flock of dogs, or hopefully not a flock of cats. That would be kind of really interesting. But all right, so what kind of diagnostics are we going to run? Actually, I'm going to take a little break, see if we have any questions. No questions at this time period. All right, so I'll keep moving on. Hopefully you guys have your coffee. We're about an hour into this. Shoot, what slide am I on? Probably I need to go a little bit quicker. I'll probably step up the pace here a little bit and stop telling the stories. All right, so what diagnostics are we going to run? We're going to start with a minimum database. So we're going to look at our CBC. So we might be able to see an anemia, oftentimes due to bleeding, whether it's just bruising at the site or systemic bleeding due to a systemic coagulopathy. Probably more of a chronic related issue. So you'll see that anemia, 2 or 3 days down the road potentially. And thrombocytopenia is certainly something that is real. We talked about that thromboxane A2 and activation of platelet aggregation, which is platelet clumping within a patient's intravascular space can lead to thrombocytopenia. We talked about echinocytosis as a possibility. This echinospherocytosis, I didn't actually realize that they were linked, and you can go from one to the next. And this is looking at a blood smear, but you see these kind of spiked cells, so they're all spiky in here. That's not uncommon to find. There's lots of people that believe in looking at the echinocytosis and seeing how bad their echinocytosis is and trying to predict outcome on patients. I haven't found that it's incredibly useful, so I actually don't even look at a blood smear unless I'm looking at trying to evaluate for a thrombocytopenia, ultimately. All right, on chemistry, you might see changes in liver values, changes in kidney values. So you might see those both being elevated. That might suggest that you have some evidence of hypoperfusion to those tissues, or maybe an acute kidney injury, acute liver injury. That might be something to look into. Elevated CK, probably present in most of these guys because they've got this tissue necrosis going on and tissue inflammation. And then if you do a UA, which I encourage you to do, not everybody's doing them, but you can often see pigmenturia. And remember that this pigmenturia can either be due to hematuria, true hematuria, or hemoglobinuria versus myoglobinuria. Those are the two that I wanted to say. So you can see hemoglobinuria due to breakdown of red cells. This echinospherocytosis can lead to rupture of the cells. You can see myoglobinuria due to tissue death. You might be able to see glucoseuria and CAS. Those would be more likely to be seen if you're developing probably signs consistent with an acute kidney injury. All right, so what else can we do? This is where we get a little bit more involved with what many people think of whenever they're talking about snake bites with regards to diagnostics. You're going to be talking about coagulation values. And these can kind of be variable. Most common things that we're going to be talking about are PT and PTT. Just as a little familiarity here, you got your Y, if you want to talk about intrinsic and extrinsic and which factors are evaluated, as well as a common pathway. So that way you can kind of sit here and be meddling through your head. All right, the PT is involving, tissue factor and factor 7. So this is what I need to provide for this patient to be able to help it out in this area. PT is prolonged. PT is going to be mostly that right wing, whereas PTT is going to be the left wing. They have all kinds of different names for this, all kinds of different assessments. But those are going to be the common things that most people run. I haven't ever done an activated clotting time. I probably should just play with that and do that sometime on my own. D-dimer concentrations, often these are actually interestingly normal, despite a hyperfibrinolytic state that's common to be found with these envenomations. Fibrin split products, which are similar to D-dimers, but not quite. I'm not going to get in, to the ins and outs of the differences between those, but those often will be prolonged. And then if you run it, fibrinogen is often decreased. So interestingly, there's this coagulopathy that they call a venom-induced coagulopathy, which more or less is interestingly, a thrombocytopenia without disseminated intravascular coagulation. This little picture over here is a close-up of what similar to DIC would look like. It's actually more likely, though, that this is an injury to a vessel and what happens with that. So kind of ignore that picture. It was just kind of a get your mind thinking about what all is involved with coagulation on patients or in patients. But this venom-induced coagulopathy is often, you'll find a low fibrinogen measurement, low platelets, normal D-dimers, increase these fibrin split products, and then prolongation of the PT and PTT. Interestingly, in these patients, this doesn't necessarily mean that they're in DIC or they're having life-threatening related issues. So this could, all these values that we can measure could mean absolutely nothing. But many people go off of these values for deciding whether or not to treat a patient with things like anti-venom or other products. And so you just got to be careful, make sure you assess the patient and not just the numbers for deciding those options would be what I would encourage you to do. All right, there is this thing called the snake bite severity score, and this is completely adapted from human medicine. But it's an assessment where you can sit here and say, all right, my patient comes in. It's kind of like the modified Glasgow Coma scale, if anybody's used that at all. But you have criteria that you evaluate, and you sit here and assign them a score and say, all right, where are we on the bad spectrum versus the good spectrum? How bad are we off? And so you're assessing different parameters for that. In my opinion, it's more often used in a serial manner to monitor changes in a patient. Are we getting worse? Are we getting better? Similar to that modified Glasgow Coma scale. I often don't condemn an animal on one measurement. So you're going to measure it serially. So often at presentation, every 4 to 6 hours or so. This is a dog that, holy smokes, talk about swollen head. I mean, he looks completely normal back here, but that body looks abnormal for how that head looks. Just impressive. And he looks miserable. I can't tell. I think that's a he. All right, so this is the snake bite severity scoring. This is pulled out of Peterson's article on the clinical techniques of small animal medicine. You can see the reference down here at the bottom, and it's been modified. So you're looking at respiratory issues, cardiovascular, the wound itself, what people call the wound, often they're not wounds, GI system, blood system, and the central nervous system. Interestingly, they have all the coagulation panel abnormalities here. Platelets is what they talk about. They do not talk about whether or not patients have a echinocytosis in this, just as a thought to kind of trigger you what's important and what's not. Again, this is an adaptation from human medicine, not a perfect thing. There is not a whole lot of information out there with regards to the snake bite severity score that I could find, at least leading up to this presentation. I did not dive deeply into looking for it. All right. Whoa, this screen looks terrible without a picture. Let's get its picture on here. That's just wretched. This is a, if you guys have any questions, please feel free to post them. I'll answer them here. But to take a little break from learning about snakes, we're going to learn more about snakes. This is a kind of a cool chart that I found, but it did have more extensive than this. I just wanted to list the first few, but the 30 most venomous snakes in the world. They define these by a lethal minimum dose, or a median lethal dose, sorry, LD50. So that dose will kill 50% of individuals that receive that dose. And this inland Taipan, or Taipan, sorry, I butchered that one, at just 0.01 mg per kg. I have no idea what mg per kg pertains to with regards to toxins. You know, is this like a drop of venom? Is this like half a drop of venom? No idea, but I'm extremely grateful. If you look at all the maps on these, none of these 6 snakes are in the United States, really. Yay, thank goodness. That's a good thing. So I'm happy for that. But yeah, so just a little break there. Any questions? No questions? Guys, we've only got 52 participants. I need 9 more to take the record for a presentation. Get out to all your friends, send them out invitations, help me out here. Just kidding. But if you guys, oh, hang on, a question. If I pester people long enough, they'll write questions. If you do not have the ability to check PT, PTT in-house, how do you determine when a patient should be sent elsewhere for this? That is a fantastic question. My answer to you would be that I decide how to treat patients based off of how they look clinically. So with that being said, I don't always recommend checking coags in a patient. Let's say a dog comes in, has a bite to the face, had some mild to moderate swelling, some pain going on, a little bit of some exudate, but just from the injection sites ultimately of the fangs. Otherwise, it's doing well. You know, that dog, I'm going to guess from my experience, it's probably going to be okay. Probably going to be okay. Do I run coags on all my snake bite dogs? Absolutely not. So I think the last one I saw through ER, our ER doctor got bit by a cat. And so I stepped in, I saw the snake bite dog. I don't even know if I ran blood work, anything at all on that dog. And I ended up sending it home on some pain medications. And I thought it was going to probably do fine. It had very minimal swelling ultimately. So if you don't have coags, it's not the end of the world. Look at your patient from a clinical perspective and decide, you know, how bad does this look? If this looks bad, consider sending them. If it doesn't look so bad, you know, maybe we can get away without doing anything. All right, next question. If snake bite can surface, effects of snake bite can surface 24 hours later, should we be performing a minute database the day of and the next day as a precaution? That is a fantastic question. Let's say doing best medicine, probably not wrong to do it 12 to 24 hours later. Most people are probably going to pay attention to coags. So PT, PTT on these patients, or in platelet counts. It's what most people in my experience pay attention to. I'm not sure that it makes a big difference. Again, from a clinical perspective, I think that if you're worried that a patient just looks a lot worse than what you would expect them to be, they haven't urinated while they've been in your care for 6 or 8 hours despite being on IV fluids, maybe it might be reasonable to check kidney values. It also depends on where they started. So they started with normal values, maybe they were going to be all right. If they started with elevated values, kidney, liver, probably want to recheck those. And then what pain med do you prefer in dogs? I'll go over that just in a little bit here when we talk about treatment. Please be patient with me. All right, so we'll go on to the next slide then. I'm sorry about that background, that's terrible. All right, so medical treatments, here you guys go. What treatments have you guys used most often in snake envenomation? Please be honest here. You're not going to be judged at all. I just want to know what you guys are used to. It might be that your answer is not on here for what you use commonly. And let's think about your average snake bite that you guys would see. I'm sorry in advance if this presentation runs longer. I had no idea. I did not expect this to go over really about 70 minutes. So please be patient. I'll try to speed up. All right, so analgesics alone for most people, about 42% of you. Steroids and pain meds, 10%. Steroids, pain meds, and antihistamines. Nobody put anti-venom. And then variations for about 19% of you. All right, so we'll talk about those here and with regards to the treatment and how I would progress through them for our patients. So like I said, the treatment's going to vary based on the severity of the patient. This patient that comes in, it's probably going to be one that I treat more aggressively than, say, that little puppy or potentially a dog that has minimal swelling at all. It just has 2 little puncture wounds. So, and then the other thing to consider is the type of envenomator. One of the lapid species, like the coral snake, those are going to be ones that I'll probably treat a little bit more aggressively. I'll monitor more closely than, say, the copperhead. Again, not every snake bite is witnessed, not every snake bite is known, so it's kind of tough to make that judgment. And then lastly, we'll talk about unique treatments, really just one unique treatment that I became very familiar with and fond of at the University of Tennessee during my residency time period there. All right, so another question for you guys. What first aid treatments have you performed on a dog that has been bitten? So what have you done, whether in the hospital or out in the wild or outside of the hospital? What of these have you done for a patient or your own pet that's been bitten? So tourniquet, manually suck out the venom like Dracula, make an incision over the puncture sites, or just icing the area. If you haven't done any of these, I guess I didn't give you a choice for not having done any of these. I guess I would say don't answer, but it might be too late now. Sorry, my bad. Oh, so we have a couple that have made incision sites over the puncture sites, some that have iced the wound. This is a lot less people participating, so I'm guessing the people that didn't participate probably do none of these things. Good, so we'll talk about each aspects of kind of this first aid treatment, what's recommended, mostly, again, pulled out of human medicine, but always nice to kind of know what people have done. So first aid, what are we going to do for our patients? Probably the most important aspect is limiting activity of that patient. So think about it in human medicine. The last thing you want to do when you get bit on your hand, if you were a human, was to kind of use that hand, flop it all around, get a bunch of blood flowing there, and then circulate all that blood and all that venom all through your body, right? Probably not ideal. So immobilizing the patient or immobilizing the limb, if they're bit on the limb, you can't really immobilize their chest cavity. I guess a head, you can't really do either. But those are some important things to do. So limit their activity. And humans, they talk about a light constrictive tourniquet. And what the goal is of this tourniquet is to try to occlude lymphatics without occluding blood flow. That's something that's really interesting. I have no idea what kind of tightness that means. I guess that would just mean a little bit less than what you occlude to draw blood, maybe. But one thing to think about is that that's probably difficult to obtain. And certainly for your client, probably going to be very difficult to know what's too tight and what's not tight enough. You still want to maintain blood flow to that area. That way you don't encourage more tissue death. So probably just avoid tourniquets altogether would be a good idea. And then local incision and suction. Interestingly, they have these devices in human medicine that are called the extractor. And I think they extract venom. So you can use them for like these things as well, which are very interesting. But they haven't been found to be incredibly useful, especially in our veterinary patients. Think about our skin. We have a lot less hair, most of us do, than our veterinary patients. So you can get a good occlusion on this. And humans can carry this around and use it on themselves. Most humans aren't going to carry this around for their pet. And you're probably not going to be able to get a good occlusion without shaving the pet pretty closely. Certainly, this is not going to be something that most of us will do. I always think back to the City Slickers scene where I forget which one got poked by a cactus, and sees a snake lying there. He's like, "You gotta suck the venom out." I was trying to look for a picture for that, but I just couldn't find anything to justify it. I was so disappointed, so I found this creepy picture. I can't tell if this person down here is smiling or if they have their mouth on the patient on the leg. It's just really creepy altogether. They kind of look more like Count Dracula here to me. But it's not encouraged to do that. So don't do that for yourself. Don't do that for your friends. It might not be very useful. And then, so that kind of takes care of our first aid. The icing is actually really an interesting thing. Icing, so ice pack and hot pack on these tissues, it's actually not recommended to do for these tissues. Ultimately, we want to encourage some degree of blood flow after the initial impact. Icing is just going to slow down the toxins. Maybe it might give a benefit to patients, but ultimately in the end, it doesn't really. Once we ice them, once they've presented to the hospital, or heat pack them once they present in the hospital, really we don't want to do that because we don't want to discourage blood flow to tissues and lead to more tissue death. And we don't want to encourage too much blood flow because that might actually cause more issues in our patients as well with regards to getting more inflammatory mediators there. So ultimately, don't recommend ice packing, don't recommend heat packing, just kind of let it run its course really. Is kind of the big thing. All right, so otherwise treating our patients. So first of all, most important, treat shock. Don't let them die because you're too worried about worrying about what antivenom or what antihistamine dose to give them. So shock dose, you guys can read all this. Quarter shock dose over 15 minutes, quarter time period. Remember that a shock dose in dog and cat is a mil per kg dose over an hour time period. We're not going to give it all at once. So dogs, you're talking about 90 mils per kg over an hour. So we're going to give a quarter of that, which is probably about 20 to 25 mils per kg over 15 minutes. Cat shock dose is 45 to 60 mils per kg over an hour. Please ignore the MIL there. Just notice that. But shock dose to try to treat hypotensive patients. Always remember to, as I said in the fluid therapy talk, I call this reassess your patient because people remember that better, but reassess your patient following an initial fluid bolus. Are they where I want them to be or do I need to give them more? And then don't forget to support the bolus. I always say these boluses are like giving fentanyl or giving lidocaine or trying to think of another similar thing. They're like a shot of liquor kind of thing. If you really want to get there and get over that hump, you really got to support it with more liquor, right? Or more alcohol. But for fentanyl, you give a bolus of fentanyl, it goes into that patient. It's going to last for about 15 minutes or so, and then it's going to come off board. But if you support it with a continuous infusion, you'll maintain those therapeutic analgesic levels. Crystalloids, if you give a bolus, that'll last about 30 to 45 minutes in the intravascular space before moving on to the interstitial space. So after that time period, if you haven't supported with just IV fluids, like a maintenance rate of fluids is enough, really, then that patient's going to become shocky again. And then some patients may require things other than isotonic crystalloids. So the isotonics are 0.9% saline, LRS, norm R, and plasma light A. So some patients may require hypertonic saline, hydroxyethyl starches, and even vasopressors. Hopefully you can avoid them if at all cost, especially the hydroxyethyl starches, because remember that they may have some effects on clotting and platelet function as well. So it's kind of a double whammy that you want to try to avoid on these patients that have been bit by snakes. All right, so a question about our analgesics. So what pain meds do I prefer? I love one that I can sit here and I can titrate and give more of if I need more of, and give less of if I need less of. Fentanyl is beautiful. Such a wonderful product. Downside is that it requires oftentimes either a fluid pump, if you put it in a bag, or a syringe pump, which not everybody has. So we go to things like hydromorphone, which is also a great product. You can adjust your dose, but a starting dose 0.1 mg per kg is very reasonable. You can absolutely go higher than that, up to 0.2, even 0.3. Unfortunately, I don't often have to go that high. Morphine, kind of a similar situation. Here's a dose for morphine as well here. So these are great products that you can use. Partial mu opioid like buprenorphine, it doesn't have the greatest ability that you can continue to get more and have less of a, not run into a ceiling effect. But it's still a good product. So if that's what you have in your hospital, by all means, give it, certainly. Remember that it's good for every 6 to 8 hours, not 12 hours ideally. So 6 to 8 is how you should give it. Lidocaine CRI, this has a couple benefits in that you can titrate it for analgesic. I wouldn't use it as a sole a sole contributor to the analgesic. So I wouldn't use just lidocaine. I would use it in combination with a pure mu like fentanyl. But it also has free radical scavenging properties that might be beneficial in these patients. And then one quick note, just soapbox here, butorphanol, negligible analgesic properties. So if you're thinking this dog's painful, I need to give some butorphanol, just go ahead and ball it up in a nice tight ball of paper and throw it into the trash can. Don't give butorphanol for pain. It does very, very little with regards to pain in the patients based on the doses that we give it. It is, for all intents and purposes, an antitussive and a sedative. Just remember that. Give pure mus are the best thing that you can give. All right, antihistamines, not currently recommended. So this is where I'm going to blow people's minds, I think. So antihistamines are not recommended. So remember that we've got two different antihistamines that we deal with. We're going to have H1 receptor blockers and H2 receptor blockers. The H1s typically are the things like diphenhydramine. So maybe have a benefit with regards to allergic reaction. But we're not dealing with allergic reactions really in these patients. We're dealing with systemic effects due to toxins, not allergic reactions. Maybe these patients that have been pre-sensitized and come in for more marked signs the second time they get bitten, maybe there's a benefit there. The H2 receptor blockers are going to be things like famotidine, and they're going to be more important for protecting the GI tract. I don't have a problem giving those in these snake bite patients to help with encouraging or discouraging rather the negative GI side effects of hypotension to the gut. So in these patients, diphenhydramine may be useful for sedating patients, decrease their activity. Ultimately, that's really for me where it kind of goes to. And then maybe for allergic reactions to antivenom. Again, that's going to be mostly the diphenhydramine. Again, famotidine, H2 receptor antagonists, mostly predominantly going to be effects in the gut. All right, next up, glucocorticoids, steroids. Not currently recommended. I'm so sorry. So many people give these. Unfortunately, there's not been evidence to show benefit of giving steroids versus not giving steroids in the studies that are done. Most of this is evaluating it in humans or evaluating in like a mouse model. There are a couple studies that do show a benefit of getting hydrocortisone at a certain dose compared to one other dose, but it's like 100 milligrams of hydrocortisone to a mouse foot compared to 10 milligrams. How are we going to extrapolate that to our veterinary patients? I have no idea what that means. And again, it's only in a very small subpopulation and not necessarily repeatable based off the studies that I've seen. So don't give it. Many people think that it might actually benefit the anti-inflammatory effects of the body with regards to how it responds to the venom. Ultimately, that's kind of a myth, more or less. Again, back to our allergic reactions, and again, back to antivenom. So you can see a type 1 allergic reaction to antivenom, so that you start to get hives or more facial swelling or itchy face, consider it for that purpose. Or a type 3, which is an immune complex reaction, which is kind of a delayed reaction. Also, you can give steroids for that purpose, but not for snake bites themselves. All right, NSAIDs, once again, not currently recommended. This one really hurts me, honestly. I love NSAIDs. They're a great analgesic, but they can have issues with alteration of platelet aggregation. So remember that we talked about thromboxane A2 earlier and how that can affect platelet aggregation and decrease it, excuse me, increase that platelet aggregation. These guys may decrease that thromboxane A2 production, which may lead to a decrease in platelet aggregation. So maybe you're battling it, but simultaneously, you could also have effects that when you need that platelet aggregation, it's not there. And so ultimately, the recommendation is not to use it. I have used it in a number of snake bites. I would go for this over steroids, but use it in caution ultimately, would be what I would say. Antibiotics. I am a big proponent of trying to use antibiotics for appropriate processes. So the big thing is empiric treatment for a snake bite. If you're just seeing a little bit of oozing from the venom site, not recommended. That does not mean, that discharge does not mean that there is an infection present. And so that's ultimately what we're going for in these patients, right? So if there's no evidence of an infection, then why give the product really? And that's kind of the important thing for these guys. So don't give antibiotics unless you have a wound present, that you have a concern, or you have confirmed that there is an active infection present. So these are animals that are 2 or 3 days down the road and they've got like pus coming out. You do a cytology and it's marked bacteria all over the place, intra and extracellular. You're just like, oh, snap. Now I've got a reason to give antibiotics, but empiric use, not recommended. All right, so really quickly, who has access to venom? I'm going to step away just to turn on the light in the room. This room got a lot darker than I was expecting, and I'll be right back. All right. Let's see who's got access to anti-venom out there. All right, so about 20% of you have access to anti-venom. Most of you have you do not have access, and one is unsure. It's kind of what I expected. Most general practitioners, I don't expect to really carry anti-venom, so I'm not ultimately surprised by that. But for those of you that do have it, congratulations, that's awesome. Use it appropriately and based on case selection. We'll go over that in just a second. I want to answer a quick question. So what about using glucocorticoids to treat the shock? Great question. So ultimately, glucocorticoids in shock are not typically recommended these days. But I guess it really depends on the type of shock. If you're dealing with an allergic reaction and anaphylaxis, absolutely glucocorticoids are recommended and useful to give. But if you're just dealing with shock in itself, so let's say we have an animal come in that's been not having to do with snake bites, been vomiting for 3 days and it's in shock. That's not an animal that needs steroids, and those steroids can actually be more detrimental to patients because remember that the shock gut in dogs, or the shock organ in dogs is the gut. You give steroids and you're going to decrease blood flow to that gut even more and then promote the likelihood that they could develop gastric and proximal intestinal ulceration. Could lead to perforation down the road eventually, but so it's not actually beneficial in shock. So that is a good question though. I'm glad that you asked it. All right, let's see what else we got. All right, anti-venom. So interestingly, I never knew that anti-venom and anti-venin were exactly the same thing. Coming into this presentation, I thought anti-venin was something specific, like a specific product. But I learned that they are exactly the same thing. I have no idea why they need two names. Sounds very, I want to punch someone in the face for kind of situation, but they're the same thing. All right, so in snake bite patients, again, it is most often not necessary to give anti-venom. It is most often not necessary to give anti-venom. I repeat it just because this is very important. It is not a benign treatment. Besides the cost associated with it, it often comes with risk as well that we'll talk about here in a little bit. All right, so what do I reserve? What do I, Nystrom, reserve the right to give anti-venom to? And just to let you know, in my 3 years as a criticalist and 4 years as a critical care resident and intern, I have given anti-venom probably 3 or 4 times myself. 3 or 4 times in a 7-year career as in critical care. In Tennessee, we didn't have quite as many snake bites as we have here, but we certainly still had a lot. But so why do I give them? So few situations, life-threatening airway occlusion. So these are the ones that get such bad swelling that it starts to occlude the airway. Let me tell you, I put up a picture of an Australian Shepherd with that big old blown up face and that hound dog with a big up blown up face. It is uncommon for these guys to get so much airway swelling that they're going to occlude. Even the ones that get bit on the tongue, I find that they often don't have enough swelling for that to be required in these guys. So not common. Unresponsive hemodynamic instability, so unresponsive shock. So these are ones that you've given a fluid bolus to, you've given a second fluid bolus to, you maybe even tried hypertonic saline if you have it available, or like a hydroxyethyl starch like vet starch or Voluben, and they're still not responding. Then you're just like, shoot, maybe this would be one that I would consider doing this because I think I'm going to fluid overload them if I keep going down this road. Concerns for marked tissue necrosis and loss, and this is one that's very tough to get people to understand and very tough to predict. So this is a dog that clearly got bit right on the chest there. And clearly you look at this and you go, oh snap, this dog is going to lose lots of tissue here. Would I consider giving anti-venom to? And this dog would be probably one that I would consider. You know, the ones that are on the distal limbs, most of the time they actually do all right. Even if they develop a small wound, they typically do all right. This one's quite impressive. So it's a tough line to walk. And then life-threatening hemorrhage due to coagulopathy, again, not very common. And this is life-threatening hemorrhage where they're bleeding, not just in the focal area of where the bite is, but they have evidence of marked bruising elsewhere. So you got marked bruising down here. I wouldn't say that's in the region of the bite. So like down here is abdomen kind of thing, or way far away, or epistaxis that's just not stopping kind of situation. And he's got bit here. So it's a tough note of when to go with that and when not to. But monitor red cell values, that would be a big thing. And then neuromuscular toxicity. So these are the coral snakes, absolutely give it, because the last thing you want is to not give antivenom and that patient need to be intubated and mechanically ventilated. No bueno there. Nobody wants that. But that's always tough to predict. Hopefully you guys aren't seeing too many of those cases also. All right, so a little bit more about antivenom. Best if given within 4 hours of envenomation. But you can give it up to 24 hours, and I've actually given it up to 36 hours later in patients, or seen it given within 36 hours. And those are patients that, like that dog, the previous dog, that they're just not doing well and they're continuing to crap the bed, really. You ideally give the infusion over 1 to 2 hours. And then remember that many dogs may require multiple doses or multiple vials. In human medicine, the average dose, I believe, is somewhere like 5 to 10 vials for a human. That's just a large volume. We have dogs that are half the weight of humans, but they're not getting, 2 to 3 vials or 2 to 5 vials. Usually we're getting 1 dose of it and thinking that's enough. But many times, if you're going to give it, you may need to get more than 1 dose. All right, risk associated with it. Probably one of the common things that fortunately we're not commonly seeing. This is mostly in human medicine, is this thing called serum sickness. This is the type 3 hypersensitivity reaction. Usually happens days to weeks afterwards, where animals come in with a dermatopathy, joint swelling, fever. These are going to be the patients that you're going to treat with steroids ultimately. So not common to occur. I think it's less than 10% in dogs, based off of one study. In human medicine, it's up to 50%, depending on the type of antivenom that they use. Allergic reactions, again, these are allergic reactions to the antivenom itself. You'll see facial swelling, urticaria, anaphylaxis. I saw this in one patient. It's one that I took over after it started getting the antivenom, and one that the owner's just like, no, we don't want to give it anymore. I'm just like, well, the dog's already getting it. It'll be all right. It'll tolerate it. It's very uncommon to see reactions. And the dog's face started blowing it more. I'm just like, oh no, pull foot out of mouth. Give that dog diphenhydramine and steroids now, kind of thing. That owner was great though. Dog did fantastic. And it was a little chihuahua, so its face just, it was epic. I used to have pictures, I lost them. I wanted to put them in this presentation. And then the last thing for risk of antivenom is the expense. It's not cheap. I think a dose of antivenom at points east costs about $500 to $600. So that's 1 vial. So quite expensive. All right, so what options do we have out there? I'm going to kind of speed through this. Oh, I'm so sorry for the time, guys. So sorry. If you have to go, by all means, go if you need to. All right, so what products do we have out there? This is antivenin crotalidate polyvalent, ACP. This is a very common one. It's also used in human medicine. This is what we actually have at Points East. The equine-derived product also has horse serum albumin in it, which doesn't quite make sense to me, but the belief is that it will help support the intravascular system. Crofab is another product. This is a polyvalent antibody to the FAB1 aspect of antibodies. So this F receptor, I'm not sure what the AB1, I forget what that stands for, doesn't really make a difference. This is ovine derived, does not have any albumin in it. Antidote 3 or Rattler antivenin, they are the same product. I have no idea why they're boxed in 2 different ways and given by 2 different companies, but they are the same exact product. They are equine derived. They come in this little bag that looks like plasma here. I actually like this product a whole lot. It's very similar to ACP, and I've had great success with it. Even though it is labeled for, it says Rattler antivenin, it is labeled for Copperheads, Cottonmouth, and water moccasin. Remember that Cottonmouth is a water moccasin, they're the same thing. But and then other things, these are things that we actually don't really have in the United States. If you look at all these, I couldn't find it. That one was not in English. This one was not in English. This one, I think someone pasted this in English. I don't think it was actually in English. So these are other products that they do have out there. The antivitamin and the polyvet ICP are not available in the United States. I'm pretty certain the Coralman is not available as well, or it might be a human-based product. So options that are out there, I would say the previous slide are the three that you're going to most commonly see. All right, so what do we do about treatment with coagulopathies? Do we recommend plasma products? Remember that fresh frozen plasma is going to contain these products. Frozen plasma, which is what happens after a year of being frozen, it becomes frozen plasma, or if it's been thawed and then refrozen, it's going to have these products. Not a big deal. I'm not going to go through all that. These are typically, let's see, they're typically not recommended. Sorry, I had to read that. It just sounded funny. So they're typically not recommended. Usually you're recommending antivenom for coagulopathies. Again, clinical coagulopathies of bleeding would be what I would clarify there. Antivenom is going to be, or antivenom is going to be the product that you want to use, not fresh frozen plasma. You can use these if the coagulopathies and active hemorrhage persist after antivenom has been administered. That's really the only indication for these guys, not just because they're PT or PTT or prolonged. So don't reach for a bag of fresh frozen plasma. Antivenom is the treatment of choice there, if you're deciding that they need it, which most of the time they do not. All right, other treatments. This is kind of the unique one, hyperbaric oxygen. I don't even know if this is a dog that got bit by a snake, but it sure looks like it should be a dog that got bit by a snake. This is something that we did at Tennessee all the time. Loved it. This was actually one of the greatest things that I have found with regards to treatment. Not a lot of people have hyperbaric oxygen though, but animals would come out of the chamber and they were acutely less painful, less swollen. They wanted to eat, they felt great. So it can help with decreasing inflammation, edema, and it's going to improve oxygenation to all the tissues around. It's quite incredible. I have no idea how it works really, but quite fascinating. All right, so what are we going to talk to these owners about? So the mortality rate will really vary. It's going to vary depending on how bad the envenomation was, so how much volume of venom, the type of snake that was envenomed, that did the envenomating, and then also the size of the patient ultimately. But mortality rates like 1 to 30%. I would honestly say that it's probably close to like 2% in my experience. I don't see a lot that actually clinically ever get very sick besides just chronic wounds potentially are the big thing. Again, we talked about it earlier, the Eastern Diamondback may have a higher mortality. It's a little bit more aggressive, large amount of venom just because of that big old jowls on them, just like a mastiff kind of situation. All right, so in summary, most envenomators in North Carolina are probably going to cause pain and some tissue necrosis. But it's uncommon in my experience that they're actually going to require significant wound care. So usually just focally stuff, cleaning them up, keeping them dry. They usually get better within a week or two. Animals can have progression within 24 hours. So just as something to put in the back of your head. But if they come in and have, oh, Siri, stop it. Sorry. But don't forget that they can get much worse. So an animal comes in that they're kind of on the teetering edge, maybe you might want to kind of keep a close eye on them for a little bit. All right, and then treatments, treat shock, antihistamine, steroids, NSAIDs, all controversial. Ultimately, don't give them. Analgesics, key success to treating a patient, making them comfortable. Antibiotics only if they have a wound and there's concern for infection. So not just empirically. Antivenom is uncommon to be required in most patients and very expensive. In plasma, really not necessary. All right, one quick plug before the end. Dr. Saker will be giving a talk next month, July 27th, 7 o'clock. She is the nutritionist at North Carolina State University. I actually went to a recent talk where she talked about doing some early intervention nutrition for ICU or hospitalized patients. Really great speaker, really great presenter as well. So I highly recommend attending this talk if you can. And then lastly, I would be happy to take any further questions. If you guys have any questions moving forward from here, here's my email. Feel free to reach out to me. I usually get back within about 24 to 48 hours. You can also get a hold of me at Points East. I'm there most days of the week during the week. But if anyone has any questions, I'd be happy to take those questions from you guys. Sorry this went so long. I got to stop talking so much. Clearly my voice isn't enjoying it either. All right, if you don't have any questions and you want to go, have a good night. Thank you very much for attending. Again, thank you to Vets Pets for putting this on, and pointsies for allowing me to be part of that team. I look forward to the next time I get a chance to talk to you. Hopefully I won't go so long. So sorry. Happy Tuesday night. Let's see, I got one question here. Oh, it's not a question, it's just a thank you. You're very welcome. My pleasure. Oh, thanks from Durham too. Oh, yay. So exciting. You're welcome. Thank you for attending.